Hello dear students, I am Dr. Mushfiq Oruzov from Department of the Pathological Anatomy of Azerbaijan Medical University. The topic of our today's lecture is Pathological Anatomy of Gastrointestinal Tract Diseases. The following diseases, about the pathology of the following diseases we'll discuss. First of all, we'll remember with you the anatomy and the physiology of the GI tract. Then we'll continue about the tonsillitis, then the disease of the esophagus, then gastric diseases, and finally we have the discussion about the intestinal diseases. I hope you remember from the anatomy course the structure or morphology of the digestive system, that is composed of two separate categories of organs. First, the digestive organs and the accessory digestive organs. The digestive organs collectively make up the gastrointestinal tract. Shortly we call as the GI tract. It also called the digestive tract or the alimentary canal. The GI tract organs are the oral cavity, pharynx, esophagus, stomach, small and large intestines. These organs form a continuous tube from the mouth to the anus. But there are the accessory digestive organs, that they are not part of the long GI tube, but often developed as outgrowths from and are connected to the GI tract. These organs assist the GI tract in the digestion of materials. The accessory digestive organs include the teeth, tongue, salivary glands, liver, gallbladder, and pancreas. This slide illustrates the anatomical structure of the GI tract organs and accessory organs. Here you see the oral cavity, the esophagus, then the stomach, small and large intestines, with the liver, pancreas, and salivary glands. Here also the very nice illustration. Let us shortly discuss about the functions of the digestive system, because it is very important to know for the understanding the pathology of this system diseases. There are some functions. First of them is ingestions. It is the introduction of solid and liquid materials into the oral cavity, and the first step in the process of digesting and absorbing nutrients. The digestion is the breakdown of large food items into smaller structures and molecules. There are two aspects to digestions. First, the mechanical digestion, that physically breaks down ingested material into smaller pieces, and chemical digestion breaks down ingested material into smaller molecules by using enzymes. The first part of mechanical digestion is mastication, the chewing of ingested material by the teeth in the oral cavity. After the materials are swallowed, they move through the GI tract by a process termed propulsion. There are two types of the movement in propulsion, the peristalsis and segmentation. The peristalsis is the process of muscular contraction that forms the ripples along part of the GI tract and forces the material to move further along the tract. The churning and mixing movements in the small intestine called segmentation, that help disperse the material being digested and combine it with digestive organ secretion. Secretion is the process of producing and releasing mucin or fluids such as acid, bile, and digestive enzymes. When these products are secreted into the lumen of the GI tract, they facilitate the chemical digestion and the passage of material through the GI tract. Some of these products, for example, the acid, bile, digestive enzymes, help digest food. Mucin secretion serves a protective function. We can show the example in the stomach, in the large intestines, that mucin fixed with water to form mucosa, and the mucosa coat the GI wall to protect and lubricate it against acidic secretions and abrasions by passing material, as I said, in the stomach, for example. Absorption involves either passive movement or active transport of electrolytes, digestion products, vitamins, and water across the GI tract, epithelium, and into GI tract blood and lymph vessels. The final function of the digestive system is the elimination of waste. Our bodies utilize the most, but not all, of the components of what we eat. All ingestible materials, as well as the waste products secreted by the accessory organs into the GI tract, are compacted into feces or the fecal material and then eliminated from the GI tract by the process of defecation. First, we'll start about the disease of the tonsils, because for the location they belongs to the digestive tract organs, for the location, for the topography, but the function, they belong to the immune system. The elements of the lymphoid tissue accumulated in the initiation part of the digestive and the respiratory tract, as well as the palatine tonsils. Here you see the lingual tonsil, the tubal tonsil, and the tonsils and the pharyngeal tonsils. Commonly they called as the Waldeyr's lymphoid ring, or the Waldeyr's Pirakov's lymphoid rings, because after the birth, the newborn, they have no completely development of the immune system. So by location here, the elements of the lymphoid tissue helps to protect our body from the external agents. And here you see the gross structure, anatomical structure of the palatine tonsils. And here we see we do the microscopic structure that they consist of the germinal center, the nodular part that covered by the stratified squamous epithelium, and here you see the section of the crypts. The infection disease of the tonsils we call the tonsillitis, or the inflammation of the tonsils called the tonsillitis. This is the infection disease accompanied by hyperplasia and other inflammatory change. They can affect the palatine tonsils or the pharyngeal tonsils or the lingual tonsils. Earlier it was called angina. That means that suffocation. It is very common in preschool and school age children, as we mentioned that these these children, the immune system not completely develops, so that these tonsils, they reactively they functions as the protective organs. There are two kinds of the tonsillitis, the acute and chronic. During the acute tonsillitis, the tonsils are composed of lymphatic tissue, as we said that, and are the component of the Waldeyr's rings, along with the adenoids, tubal tonsils, and lingual tonsils. This is the that we discussed now. And tonsillitis is a common disease and makes up to approximately 1.3% of outpatient visits. It is predominantly the result of viral or bacterial infection, and they uncomplicated present as a sore throat. Acute tonsillitis is a clinical diagnosis. The differentiation between bacterial and viral causes can be difficult. However, it is crucial to prevent the overuse of antibiotics. Etiology they develops by the action of the staphylococci, pneumococci, adenovirus, and various microbial associations. Pathogenetic factors, they divided into two parts, exogenic and endogenic. The endogenic factors are the common cold, the consumption of the cold water and substances, traumas of the mucous membranes of tonsils. But the endogenic, it may be the weakened immune system, age features of the lymphoid ring, autoinfection such as the caries, chronic pulpitis, chronic laryngitis, chronic pharyngitis, retropharyngeal infection, and etc. Which complications we can miss during the acute tonsillitis? They divide it into the local and the general. Local complications maybe the peritonsillar abscess, the retropharyngeal abscess, pharyngeal phlegmon, thrombophlebitis, acute otitis media, and the general, the tonsillogenic sepsis, post-streptococcal glomerulonephritis, and rheumatic fever, and etc. There are some clinical morphological types of the acute tonsillitis dependent on the characteristics of the pathogenetic process. From the general pathology, you remember the catarrhal tonsillitis, the serous mucosa exudate appears on the tonsillar mucosa, and the catarrhal tonsillitis is a part of the generalized pharyngitis that is seen in viral infections. Another kinds of the fibrinose or the membranous tonsillitis that characterized by the formation of the whitish, yellowish, diphtheritic fibrinose membrane on the surface of the mucosa. Then purulent or the suppurative tonsillitis. There are two types of the purulent tonsillitis from the general pathology. Again, you probably remember about the kind of this inflammation that they reach with the neutrophils. If they diffusely in the tonsilla, we call the phlegmonous tonsillitis. Or they, if they located as the small abscesses, apostemas, we call the apostematous tonsillitis. There are two types of the tonsillitis, acute tonsillitis, that they classified for the localization. One of them is lacunar tonsillitis. The serous, mucous, or purulent exudate accumulated in the tonsillar lacuna, and here forms the false membranes, not true membranes. And follicular tonsillitis, that the pathologic process they covered, they located in the tonsillar cribs. So another types of the tonsillitis, acute tonsillitis, is the necrotic tonsillitis, and here forms the wounds when the necrotic mass ruptures. We call the necrotic ulcerated tonsillitis. Gangrenous tonsillitis. This is the special types of the acute tonsillitis that usually found in the children with acute leukemia or the scarlet fever. So at this time the tonsils grow in size and appear greenish black. One of the also the special types of the acute tonsillitis is Vincent's tonsillitis or the Vincent's angina, or the ulcerative membranosus tonsillitis, or the Szymanowski-Plowince tonsillitis, that is usually epidemic, that they caused by the combined action of the Spirochetes and the Fusobacteria, Fusobacterium fusiforme. This here you can see the acute catarrhal or the superficial tonsillitis, then acute membranous tonsillitis or the acute fibrinous tonsillitis, and here we see we do the acute follicular tonsillitis. The histology of the acute tonsillitis, as we said, we can find here the apoptotic bodies, then foamy histiocytes, the abundant foamy histiocytes, and the phagocytic histiocyte we can find in the acute tonsillitis. Chronic tonsillitis may be a complication of the acute tonsillitis, the subclinical infection of tonsils without acute attack. The allergic factors play an important role in the pathogenesis of the chronic tonsillitis. Chronic infection of the paranasal sinuses or the teeth may be a predisposing factor, often accompanied by recurrence. The palatine tonsils are deformed by diffuse sclerosis, often shrinking in size. There are numerous sclerotic adhesions with surrounding soft tissue. Chronic tonsillitis is sometimes accompanied by purulent pharyngitis or the pharyngolaryngitis. Chronic tonsillitis act as a source of endogenous infection as well as the rheumatic fever. There are three types of the chronic tonsillitis: chronic follicular tonsillitis, chronic parenchymatous tonsillitis, and chronic fibrotonsillitis. The clinical features are the recurrent attacks of acute tonsillitis, chronic irritation in throat and cough, and bad taste in mouth and foul breath. We call this halitosis. This slide illustrates the normal and the pathology of the tonsils during the chronic tonsillitis. In the normal surface epithelium, we do the stratified squamous non-keratinized surface epithelium and no anal lymphocytes. But here in the surface epithelium, we see the scattered small lymphocyte groups in moderate lymphocytes infiltration in the surface epithelium and the lymphocytes in the subepithelial region. The esophagus, this is the tubular part of the GI tract, approximately 25 centimeter long. And as you know that the esophagus, they connected the oral cavity with the stomach, and it has layers, consist of the layers such as the mucosa, submucosa, muscular layer, and the adventitious layer. That is general structure of the wall of the tubular organs as well. And you know that the mucosa here in the esophagus is covered by the stratified non-keratinized epithelium. Here you see, and the mucosa also have the lamina propria and the muscularis mucosa. Then we see here the submucosa and the muscular layer that consists of the internal circular and outer inner circular and outer longitudinal layers. And you know that the muscle tissue consists of the skeletal muscles in the upper 1/3 of the esophagus. In the middle 1/3 is mixed with the skeletal and the smooth muscle, and the lower 1/3 is certainly consists of the smooth musculature. The diseases of the esophagus mainly they are the hernias of the esophagus and the infection diseases, reflux esophagitis and Barrett's esophagus as well. And here you see the grouping of the esophageal diseases. The first, the reflux esophagitis, the Barrett's esophagus, and the strictures. These are most common diseases of the esophagus, and less common diseases are the Pylori waste syndrome. It is the bleeding to the rupture of the mucosa of the transition zone between the esophagus and the stomach with severe vomiting. Then the varices, as I said, the hernia, the Zenker diverticulum, tracheoesophageal fistula, and the Plummer-Vinson syndrome, that is the rare diseases that are characterized by the difficulty swallowing, iron deficiency, anemia, glossitis, cheilosis, and esophageal verbs. From this illustration, you see the some diseases that they show here: the achalasia, cardia, then hiatal hernia. We see here, then hiatal paraesophageal hernia, rolling, Zenger diverticulum, the epiphrenic diverticulum, and the Pylori vase tear syndrome. The esophagitis characterized by damage and inflammation of the epithelial lining of the esophagus. There are three major etiological groups of the esophagitis. First, the infection esophagitis, chemical esophagitis. This is the most common form, and the esophagitis as a manifestation of other disease. The main cause of gastroesophageal reflux, the reflux of the contents of the stomach, sometimes the duodenum, into the lower esophagus. Another cause may be infection factors. But the histological features are not entirely sensitive and specific for esophagitis. That clinical and endoscopic information can be very useful in the diagnosis of the esophagitis. Clinical signs include dysphagia, nausea, vomiting, chest pain, stenosis, and eating disorders. Here is another classification of the esophagitis, the clinical morphological types of the esophagitis, the reflux esophagitis, eosinophilic esophagitis, lymphocytic esophagitis, necrotic esophagitis, or another that we call it the sloughing esophagitis. Then Crohn's disease affecting the esophagitis, peel esophagitis, during the using of some drugs, medicines, for example, antibiotics, especially of the tetracycline family, non-steroid anti-inflammatory drugs, and etc. Then infectious esophagitis and skin disorders affecting the esophagus. Now let we investigate the reflux esophagitis. Here you see the endoscopic appearance of the ulcerative esophagitis that's secondary to the severe gastroesophageal reflux diseases. Histologically, the gastroesophageal reflux disease is characterized by increasing the basal layer thickening, elongated papilla, here we see with you, and the mild inflammation with occasional eosinophils. And the first step during the esophageal biopsy, we do the founding searching for the eosinophils. This is the clue marker for the diagnosis of the esophagitis. Eosinophilic esophagitis with characteristic rings known as the trachealization visible in the endoscopy, and here in the histologic slice we see also the basal cell hyperplasia, elongated papilla, and also we can see the increasing the abundant number of the intraepithelial eosinophils, that more than 15 in the one high power field. Another kind of the esophagitis is the infectious esophagitis. Here you see the esophagitis is affected by the candida, the fungi. Here you see the hypha of the candida. Then herpes esophagitis. Here we see with you the multinucleated ground glass inclusion inside of the cells with the chromatin margination and molding. Then during the cytomegalovirus infections, we see with you the inclusions within the stromal cells and immunohistochemistry for cytomegalovirus. That here the arrows highlights the multiple inclusions. Another disease of the esophagus is the Barret's esophagus. The American College of Gastroenterology definition of the Barret esophagus is that extension of salmon-colored mucosa into the tubular esophagus extended more equal 1 centimeter proximal to the gastroesophageal junction with biopsy confirmation of intestinal metaplasia, goblet cells. Etiology of the esophagitis are the chronic, more than 5 years gastroesophageal reflux disease symptoms, the advancing age, more than 50 years, the male gender, tobacco using, central obesity, and Caucasian race. So most common in first degree relatives of subjective with non-Barret esophagus. Where located the Barret esophagus, especially in the distal esophagus and the gastroesophageal junction. Pathophysiology of the Barret esophagus. The metaplasia in the Barret esophagus presumably results from cellular reprogramming. The gastroesophageal reflux disease induced tissue damage, reprograms immature progenitor cells to express columnar development transcription factors. The tissue injury activates signaling pathways such as the head jock, the bone morphogenetic protein 4, nuclear factor kappa, and the downregulation notch signaling. The signals lead to increased expression of the SOX9, the induced columnar differentiation, FOXA2, CDX1, and CDX2 that induce the intestinal differentiation. Transdifferentiation, the distinctive type of the multilayered epithelium at the squamous columnar junction with features of both squamous and columnar epithelium may occur in Barret esophagus. The clinical features same with the gastroesophageal reflux syndrome. Grossly, as we said in the definition, the red or the salmon-colored mucosa between pale squamous mucosa of lower esophagus and lush pink gastric mucosa may have tongues extending up from gastroesophageal junction. The endoscopics utilize the Prague classification to describe disease extent in Barret mucosa. Here we do the endoscopy of the Barret esophagus in the gastroesophageal junction, and here we see the intestinal metaplasia, the columnar epithelium with the goblet cells. Let we discuss about some microscopy description of the Barret esophagus. Here we see the abundant number of the goblet cells that are characteristic for the intestinal metaplasia. Here we see the true goblet cells that randomly scattered, barrel shaped, here we see, or the circular shaped with a bluish cytoplasmic hue. And also we can find the pseudogoblet cells, that they are the goblet-shaped gastric foveola cells that are they clustered and characteristically arranged in the liner or the back-to-back. Here we see the reactive Barret mucosa that shows the 4 lines. The first line, here we see the gastric foveola type mucin droplets. Then second line, the base of the foveola mucin vacuole. Third line, here we see the cytoplasm below the mucin vacuole and the nuclear row of the nuclei here in the epithelium. So this is the 4 lines in the Barret mucosa. Then in the Barret mucosa also we can find the hybrid glands that consist of the mixed metaplastic with the goblet cells and the mucinous epithelium, and the high specificity for the Barret mucosa. Another histologic features is the basal glands in the Barret mucosa, that here we can show the nuclear stratification and elongation. Another histologic sign is the squamous epithelium that overlying the glands with the intestinal metaplasia. You see here the squamous epithelium and underlying the columnar epithelium, the intestinal epithelium with the goblet cells. Also the duplication of the muscularis mucosa. This is the characteristic features in the Barret esophagus. Here we see the star highlights the inner muscularis mucosa, and the arrow highlights the native or the outer muscularis mucosa. Now we'll discuss about the diseases of the stomach. From anatomy, you remember the structure of the stomach. This is the enlarged portion of the dilated portion of the GI tube, approximately with the 3-liter volume, and it has the cardiac region, the entrance region, the body with the fundus, and the pyloric region that they separated to the intrum, and the canal, the pyloric canal region. With the lesser curvature, you know, the greater curvature here, and the histology of the stomach, as we said in the esophagus, they consist of the mucosa with the covering foveolar epithelium, the lamina propria, and the muscularis mucosa with the submucosal layer, and the muscularis externa, that outside the stomach, surrounded with the peritoneum, that it is the intraperitoneal organ. And the histologic structure, here we see the high power of the mucosa with the epithelial, foveolar, or the glandular cells, the lamina that located in the lamina propria. We call it the gastric glands. They dispersed in the fundus region, the pyloric region, the cardiac region. Most commonly, they located in the fundal region. And the gastric glands, they have some different cell types, as well the zymogenic chief cells that they produce the pepsinogen, then parietal or the oxyntic cells that they produce the hydrochloric acid, then mucous cells that they are the two types of the mucous cells that located in the neck region, and also in the surface lining cells. Here we see with you the stem cells or the regenerative cells, with also the intraendocrine cells, the cells of the acute system. For example, the major hormone that they produce in the stomach is the gastrin. Here we see the fundus mucosa with the parietal and the chief cells, and the antral mucosa with mucin secreting glands. And after the anatomical, histological, and physiological features, that physiology include that you know that the gastric juice that produced by the gastric glands, they mixed with the food elements, and here forms the chymus, that the mainly the proteins they undergo the digestion in the stomach, that they serve to the simple peptides. The the gastritis is the inflammatory process, inflammation of the stomach. The risk factors for the gastritis are the drugs that direct irritating the effect of the gastric mucosa, such as the aspirin, the non-steroid anti-inflammatory drugs, and corticosteroids. Diet, as well the alcohol, using the spicy food, microorganisms, the Helicobacter pylori, that important cause of the chronic gastritis, that promotes the breakdown of the gastric mucosal barrier. Also the staphylococci maybe play as the risk factor role. Environmental factors, the radiation, smoking, pathophysiological conditions such as the burns, renal failure, sepsis, and other factors. For example, the physiological stress, nasogastral tube. There are two types of the gastritis: the acute gastritis and the chronic gastritis. The acute gastritis is the acute inflammation of the gastric mucosa, depending on the region of the occurrence, there are diffuse and focal acute gastritis. The etiology include both exogenic and endogenic factors. The exogenic factors are the elementary, toxic, medicamentous, infectious, and erosive. The endogenic include the endemic, intoxication, ischemic factors, the circulatory, neurotic, and the sepsis. There are four classic types of the acute gastritis you remember from the general pathology. Also, we discussed in the tonsillitis, for example, cultural gastritis. Here we see the dystrophy, necrobiosis, necrosis, and erosions that they only localize in the mucosal epithelium. Then fibrinous gastritis, if the necrotic layer is thin, here will develops the Kruppe's fibrinous gastritis, if deep diphtheritic gastritis. The phlegmonous gastritis, the purulent exudate is formed in the mucosa and submucosa, and necrotic acute gastritis. Mainly they develops after the action of the erosive substances such as the acids, alkalis. We call this the corrosive gastritis. Here we see the grossly structure of the acute gastritis and the histology of the acute gastritis, that in the lamina propria we see the neutrophils, polymorphonuclear lymphocytes. Here we see the chronic gastritis is defined as the presence of chronic mucosal inflammatory change, leading eventually to mucosal atrophy and intestinal metaplasia, usually in the absence of erosions. Etiology, there are two etiological factors for the chronic infection by Helicobacter pylori and the immunologic factors in association with pernicious anemia. We will use some different classification for the chronic gastritis. One of them is a pathogenetic classification, or the according to the pathogenetic mechanisms. There are three types of the gastritis: A gastritis, B gastritis, and C gastritis. The A gastritis, another name is autoimmune gastritis. That this is the autoimmune disease, forms the autoantibodies against the parietal cells of the gastric glands, that they produce the hydrochloric acids, also known as the fundal or the hypoacid gastritis, because the parietal cells they damaged by the autoantibodies, and they can't produce the hydrochloric acid, and their stomach became to the hypoacid environmental. And the B12 deficiency anemia is developed here, that we call the pernicious anemia, for the deficiency of the internal factor of the castle. B gastritis, this is the Helicobacter pylori gastritis, that 80% of all chronic gastritis mainly localized in the antrum of the stomach, that caused by the Helicobacter pylori. C gastritis, this is the duodenogastral reflux that occurs in the patients after gastric resection. In 30% of such patients, it develops the antral chronic gastritis. Here you see another classifications of the chronic gastritis. First, according to the localization, the fundal pangastritis, antral gastritis. According to the activity, active gastritis, or the chronic active gastritis, chronic non-active gastritis. According to the clinical course, there are mild, moderate, and severe gastritis. According to the morphological features, there are the superficial, atrophic, and hypertrophic gastritis. We mainly will focus to the morphological features, or the pathogenetic features of the gastritis with the activization. The chronic superficial gastritis, this is mainly caused by the Helicobacter pylori, and here mucosa is normal thickness. The main morphological change occurred in the upper 1/3 of the surface layer. We can find here the degenerative change in the epithelium, but sometimes the metaplasia. But do not confuse this metaplasia with the intestinal metaplasia. The students mainly they confuse in the exam questions. This metaplasia sometimes we can note here, and the lympholeukocytic infiltration and edema occurs in the lamina propria. The chronic superficial gastritis can remain in the same condition for many years without any progression. Here you see the lymphoid follicle formation in the lamina propria of the stomach. This is the clue histologic features of the Helicobacter pylori gastritis. Here under the high power we see with you the Helicobacter pylori microorganisms with the special Giemsa stainings, and here you see the immunohistochemistry for the Helicobacter pylori. Here I add for you the electron micrograph of the Helicobacter pylori with the 3D structure, and also the immunohistochemistry of the Helicobacter pylori microorganisms. Another types of the gastritis is chronic atrophic gastritis. Here we can find the atrophy at the sclerosis in the lamina propria, and the major features of the chronic atrophic gastritis instead with the together with the atrophy of the glands, the finding of the metaplasia, especially the intestinal metaplasia with the goblet cells. Here we see the presence of the abundant goblet cells in the stomach. Normally, you know, the cells absent in the covering epithelium of the and the glandular epithelium of the mucosa, and you see here the mucous lining, as you know that the covering epithelial cells of the stomach also they can produce the mucus that they prevent the cellular structure, prevent the wall of the stomach from the acid environment of the lumen. Sometimes we use the Sidney system of grading the chronic gastritis. We can note the site of the diseases, enteral or the corporal mucosa, and the grading of the inflammation, mild, moderate, marked for the checking of the Helicobacter pylori presenting, chronic inflammation, activity, atrophy, and intestinal metaplasia. How we can show the activity? If we found here the neutrophils, we diagnose this as the chronic active gastritis because the no any neutrophils in the lamina propria in the norm. But normally the some lymphocytes and the plasma cells we can find in the lamina propria up to the 5 in the high power field. But not all of the labs they use the Sidney system. It depended on the hospitals and the pathologists. Third types of the as called the gastritis is the chronic hypertrophic gastropathy. This is not true gastritis. The inaccurate name. This is the hypertrophic gastritis. There are three diseases that we can find this hypertrophic gastropathy. One of them is Menetrier disease that resulting from profound hyperplasia of the surface mucosas with accompanying glandular atrophy. Second, hypertrophic hypersecretory gastropathy that associated with hyperplasia of the parietal and the chief cells with gastric glands, and the gastric gland hyperplasia secondary to excessive gastrin secretions, for example in the gastrinoma, in the Zollinger-Ellison syndrome. This slide illustrates the gross pathology of the Menetrier disease or the chronic giant hypertrophic gastropathy. Also here we see with you, and the histologic features of the chronic giant hypertrophic gastropathy. You see here the hypertrophy of the gastric foveolus. Instead, we'll discuss about the ulcer disease, the peptic ulcer disease, of the stomach. But there are also the symptomatic ulcers that develops as a signs of other diseases. First, let we discuss about the symptomatic ulcers. Then we will continue with the peptic ulcer diseases. The endocrine ulcers. They develop during the some endocrine diseases such as the Ellison-Zollinger syndrome, thyrotoxic goiter, the parathyroidosis. Then the ulcers resulting by the hemocirculatory disorders. For example, they will call it congestion ulcers during the cardiovascular insufficiencies and different vasculitis or the cardiovascular failures. The medicamentous ulcers during the treatment with the steroids and the aspirins, toxic ulcers, chronic infections ulcers, for example, some specific inflammation, the tuberculosis, syphilis, leprosy, and etc. One interesting types of the ulcers is the stress ulcers. For example, during the shocks, the burn disease, sepsis, after the severe operations, in the central nervous system lesions, we call this Cushing ulcers, or the burn disease, we call the ulcers during the burn disease, we call it curling ulcers, etc. And allergic ulcers and etc. Also, these are the symptomatic ulcers. The peptic or the chronic ulcer disease is the relapsing, usually solitary lesions, most often diagnosed in middle age to older adults, occur in any portion of the gastrointestinal tract, but mainly they are located in the body of the stomach. And there are three characteristic localization of peptic ulcers. As we said, the ulcer of gastric body, mediogastral ulcer, the pyloric ulcer of the stomach, and the duodenal ulcer that also separated to the bulbar and the postbulbar. And there are two types of peptic ulcer according to the pathogenetic features that they have the different pathogenetic mechanisms. One of them mediogastral ulcer, and second one pyloduodenal ulcer, that most common types of the ulcers. About the etiology and pathophysiology of the peptic ulcer disease, some acid does seem to be essential for a gastric ulcer to occur. So under specific circumstances, the mucosal barrier can be broken and the hydrochloric acid freely enters the mucosa and injury to tissues occurs. And this results in cellular destruction and inflammation. And after this one, the histamine is released from the mast cells that results by the vasodilatation, increasing capillary permeability, and further secretion of acid and pepsin. The pathogenic factors of the peptic ulcer diseases: infection. For example, the Helicobacter pylori is found in 90% of duodenal and 65% of gastric ulcer patients. Neuroendocrine factors. The secretion of the gastric juice is under the neuroendocrine control, which becomes dysregulated in peptic ulcer patients. Then local mucosal factors, drugs such as non-steroid anti-inflammatory drugs that reduce the secretion of the prostaglandins and damage the mucosal barrier. Alcohol, spicy food, and substances that stimulate acid secretion may play a pathogenic role. This table demonstrates the comparison of the pyloduodenal and the mediogastral ulcers. The pyloduodenal ulcers appears more than 4 times in comparison with the mediogastral, that they appears few times. age in the pyroduodenal ulcers, young and middle-aged patients, but in the mediogastral ulcers, they affect the older adults. The pyroduodenal ulcers mainly found in the develops in the males, but in the mediogastral ulcers they mainly develops in the females. Condition of adjacent tissue. The adjacent tissue in the pyroduodenal ulcers is normal, but in the mediogastral ulcers here develops the inflammation, the chronic gastritis. Gastric acidity high in the pyroduodenal ulcers, low in the mediogastral. The pyroduodenal ulcers develops in the persons with usually first blood group, but in the mediogastral ulcers, persons with the usually second blood group. For interesting facts also. There are three morphogenetic periods, stages of the peptic ulcer disease. First, let me remember you that the peptic ulcer disease is not related with the inflammation. Not related with inflammation. Of course, here also develops a secondary inflammatory change, but primary this is not inflammatory diseases. These diseases manifested with the degenerative, necrotic, and sclerotic change. First stage is erosion. This is the damage of the covering mucosal epithelium. Second one, the acute ulcer stage that develops as a result of penetration of the necrotic process into the deep layers of the gastric wall. And finally, the chronic ulcer, as we said, that substrate is the chronic ulcer, that last phase of disease. The pathological change during the peptic ulcer disease can penetrate and destroy the muscular layer with the alternation of recidivating and remission periods. The peptic ulcer disease have a typical distribution. 95% is located in the posterior end of the lesser curvature, and most occur in the pyros, because this is, the way of the food. Almost is solitary, but in 5-10% the second ulcer may be found on the anterior aspect of the pyroid canal. Grossly, it sharply demarcated round or oval defect of mucosa, known as the ulcus rotundum. Most ulcers are small, approximately 1.5 to 2 cm. The bottom is smooth. The hydrochloric acid and pepsin keep it clean, but it may be covered by blood. Borders of the ulcers are shaped, but around the long-lasting lesions, the adjacent mucosa may show some puckering due to fibrosis. The vessels trapped within the dense scar tissue replacing muscles show endarteritis. The crater fills with granulation tissue, followed by re-epithelialization from the margins by healing. Extensive fibrous scarring occur here. Here develops the phenomenon callose ulcer. What meaning it? The fibrous ulcer margins can be evaluated above the surface. Frequently, the ulcerated process extends to the serosa or even beyond it. And the extension of the inflammation to the serosa may result in adhesion to adjacent organs, such as pancreas. We'll discuss it during the complications. And the ulceration may burrow into the affected organ. The remainder of the stomach frequently shows the features of the chronic atrophic gastritis, because the chronic atrophic gastritis develops during the diseases that we'll discuss later about the inflammatory complications. And healing appears in 6-8 weeks. This is the gross view of the gastric peptic ulcers. As you see here, this is the dark black color by the formation here of the hemosiderin by the action of the hydrochloric acid to the erythrocytes that they extravasated from the blood vessels here. And here you see the double ulcers on the stomach. During the activation in the ulcers, we can find the 4 histologic zones or the layers. The superficially, it is the exudative zone. This is the purulent necrotic zone, or we call it the dusty layer. You see here the ulcerated mucosa that we call it the superficial exudative zone. Second one, the fibrinose necrosis, zone of the necrosis. Then granulation tissue, we see here, or the this is the new formatted develops the connective tissue, and the fibrous tissue that we can find here. Endoscopically, during the activation, the endoscopists, they show the granulation tissue. They call it the red scar. But during the remission, they see the whitish structure that they morphologically they related to the scar tissue. So let me repeat the first layer, this superficial exudative zone, then white zone of the fibrinose necrosis, granulation tissue, and the fibrous collagenous scar. The presence of the fibrinose necrosis, you remember, it's a marker of the activity. Let me discuss about the complication of the peptic ulcer diseases. We can group it in some groups. First, we call it destructive or the necrotic complications, the hemorrhage, perforations, and penetrations. The hemorrhage is bleeding from the blood vessels that are located in the base of the ulcers that occurs due to the fibrinose necrosis. It's evident in 1/3 of patients and may be life-threatening. Most commonly, it is of minor degree, which can only be detected by testing the feces for iron. Because this is the chronic bleeding, leads to the anemia. So more marked hemorrhage may actually cause discoloration of the feces. We call it melena. Probably you remember from the hemocirculatory disturbances, we discussed it. Or the tarry stools, due to the formation of iron sulfides. Also, the coffee grounds vomiting may occur here. Perforation, this is the ruptures of the wall of the stomach, you see here. And after this one, the contents of the stomach opens to the peritoneal cavity to lead the development of the peritonitis. Second group of complications is the inflammatory complications that we call it, for example, the peri-ulcerous gastritis, the inflammation around the ulcers, perigastritis, duodenitis, and periduodenitis. And sclerotic complications. When the ulcer healing, they can result in muscle drawing up by scar tissue that show the stellate contractions. Also, hourglass stomach that is found during the radiologic X-ray examination of the stomach. Pyrostenosis, obstruction, this is also the sclerotic complications. Duodenostenosis, and the deformation of the duodenum. The peptic ulcer disease, the long-standing types, without the correct treatment, they can develop to the carcinoma. So the chronic atrophic disease, chronic atrophic gastritis, this is also the pre-cancerogenic disease of the stomach, and the chronic peptic ulcer disease also the pre-cancerogenic disease of the stomach. But you have remembered that the chronic atrophic gastritis more worse than peptic ulcer disease. The next group is common and alimentary complications. The alimentary cachexia, peptic disorders, metabolic disturbances, and etc. And finally, the combined complications. Here you see the gross pathology of the stomach with the sclerotic complications. You see here the fibrosis due to fibrosis and the contraction of the stomach that leading to hourglass shape, as well as the altered mobility of the stomach. It is found during the X-ray examination. Now let me discuss about the intestinal diseases. There are, two types of the intestine, the small and the large intestines, or we call it bowels. There are inflammatory diseases, enteritis, colitis, appendicitis, degenerative diseases, enteropathies, vascular diseases such as acute and chronic ischemic diseases, angiodysplasia, hemorrhoid, and etc. Tumors, polyps, carcinomas, and developmental abnormalities such as the megacolon, megasigma, diverticus, stenosis, atresia, and etc. Now we'll discuss about the enteritis. This is the inflammation of the small intestines. That there are two types of the enteritis: acute and chronic. Duodenitis we call the inflammation of the duodenum, jejunitis, inflammation of the jejunum, and ileitis, the inflammation of the ileum. Acute enteritis. There are four etiologic factors of the acute enteritis. First, the infections such as the typhoid, cholera. About the enteritis we'll detailedly discuss during the infection diseases. For example, in the cholera we'll discuss about the cholera enteritis, during the typhoid, also during the sepsis. Toxic agents, the alimentary toxin infections such as the salmonellosis, botulism, poisoning. Alimentary agents, hyperalimentation, the use of the rasping food, spices, strong alcohol drinks. Allergic agents, idiosyncrasy or to foodstuff, medicines. The clinical signs and symptoms of the acute enteritis are the diarrhea, nausea and vomiting, loss of appetite, abdominal cramps and pain, bleeding or mucus-like discharge from rectum, fever, dehydration, and weight loss. Here you see the types of the acute enteritis according to the pathogenesis. We discussed about the gastritis, tonsillitis, the same types: the catarrhal, fibrinose, suppurative, and ulcerative. This slide illustrates the histopathology of the acute duodenitis. That the neutrophils, eosinophils, this is the found without the searching. You see here the low, middle, and high power field, and you see here the neutrophils with the abundant number of the eosinophils. And sometimes you can find here the plasma cells and the intraepithelial lymphocytes. Here you see the intraepithelial lymphocytes. The etiology of the chronic enteritis. First, irregular alimentation, dietary disturbances, alcohol abuse, industrial, domestic, and medicamentouse poisoning, food allergy, helminthosis, and endogenic autointoxications, and etc. Also, the chronic enteritis divided into two types: the chronic atrophic enteritis and chronic non-atrophic enteritis. That they also subdivided to the chronic superficial enteritis and chronic diffuse enteritis. Whipple disease, another name intestinal lipodystrophy or idiopathic steatorrhea. Whipple disease is a rare systemic infection disease caused by the bacterium Trophirima whipplei that first described by George Hoyt Whipple in 1907. Whipple disease typically present in middle-aged Caucasian patients with a striking male to female predominance of 8 to 1. It can affect virtually any organ system. Typical signs and symptoms are the lower grade fever, chronic weight loss, arthritis, malabsorption, and lymphadenopathy. Many patients also have significant neuropsychiatric manifestations. The polyarthritis of Whipple disease is often the first manifestation and may precede gastrointestinal symptoms by years. Immunosuppressive therapy may significantly exacerbate both the intestinal and systemic manifestations of the disease. The histopathology of Whipple disease. The Whipple disease, and during the biopsy, there are two major histologic features. First of them is foamy macrophage that they engulf the lipids, and they are the PAS positive macrophage. Here you see the PAS positive macrophage, and here you see also the staining of the goblet cells with the PAS stains. But we have to focus the accumulation, the abundant number of the macrophages. And then the lamina propria often contains the small foci of fat and the overlying devascularization of the enterocytes. Another disease is appendicitis, inflammation of the appendix vermiformis absecum. Auto-infection play major roles in the etiology of the diseases that are related with intestinal microflora, especially the Escherichia coli, enterococci, and etc. And the background for the appendicitis, the impaction of the lumen by the fecal and bile concretions, rasping food, foreign bodies, wound accumulation, and etc. And disturbance in blood and nerve supply of mucosa and spasm of the lumen of entering. Mainly in the clinics we use the acute appendicitis term. Before they not accepted the chronic appendicitis, but now it acceptable by the clinicians and the pathologists. There are three types of the acute appendicitis: the simple, superficial, and destructive. The simple and superficial appendicitis are irreversible processes, but if the destruction develops here, this is the the simple and superficial appendicitis are the reversible processes. This is a mistakenly reversible processes. But the destructive process not irreversible processes. That they continue the phlegmonose, apostomatose, ulcerative, and gangrenose process. Acute phlegmonose appendicitis. Here we see the gross appearance with the unfixed specimens, and the appendix is swollen and the red due to the hemorrhage. And here we see the microscopic structure histologically, that the epithelium here absent is denuded, and there is marked severe inflammation. And the inflammation and the hemorrhagic spans the entire appendix wall. We can correctly investigate the acute appendicitis, and sometimes the surgeon they not tend to send the appendicitis material to the pathology labs, but sometimes in the tip of the appendix we found the malignant tumor of the gastrin producing cells. We call it the carcinoids. Here you see the gross view of the carcinoids and the histologic structures in the lower power and the high power. This is the neuroendocrine cancers or the carcinoid. The complications of acute appendicitis due to the progression of destructive processes and the spread of the purulent process of the other nearby organs and tissues. They include the perforation, local and diffuse peritonitis, empyema and abscess, periappendicitis, peritymphitis, suppurative thrombophlebitis, and the portal pilophlebitis, and chronic appendicitis and adhesions. The chronic appendicitis develops as a complication of acute appendicitis. We can find the atrophy of the tunics of the appendix and development of the sclerotic tissue, the fibrotic tissue, that they lead to the dyskinetic disturbances and accumulation of the contents inside of the appendix vermiformis that may be results of the hydrops of the appendix, the accumulation of the contents, activation of the inflammation and gangrene of the appendix. I would like to say you that not all of the surgical operations for the clinical diagnosis of the appendicitis that not they supported by the pathological diagnosis. Approximately 25% of the surgical operations for the appendicitis, 25%. This is the true operations. Sometimes the another diseases may mimics the acute appendicitis, such as the intestinal problems, the pains or the spasms, pains of the intestines, or the maybe the problems with the genital organs, maybe inflammation of the kidneys or the stone disease of the kidneys, and etc. And here we see with you the chronic appendicitis, the histopathology, that prominence, the fibrosis and the fatty infiltration we can find in the wall of the appendix. Colitis, the inflammation of the mucosa of large intestines. There are two types of the acute and chronic for the clinical course and morphological features. According to the location of the inflammatory process, there are typhlitis, inflammation of the cecum, transversitis, inflammation of the transverse colon, sigmoiditis, inflammation of the sigmoid colon, proctitis, inflammation of the rectum, and the pancolitis, inflammation of the all parts of the large intestines. The etiology of the acute colitis. The infection colitis, during some infection diseases will meet with the development of the colitis in the dysentery, salmonella, staphylococcal, Escherichia coli, typhoid, also the fungi, parasites, tuberculosis, syphilitic, septic colitis, etc. Then toxic colitis, for example, the uremic, gut, medicamentous, and mercury chloride colitis, and toxic allergic colitis, as well as the alimentary and coprostatic colitis. There are following types of acute colitis: the cataract colitis with the mucous serose, suppurative and mixed inflammation; fibrinous colitis, the purulent phlegmonous colitis; hemorrhagic colitis; necrotic colitis. There is a special types, the gangrenous colitis and ulcerative colitis. Chronic colitis develops as a result of acute colitis factors, but with low intensity and long-term consequences. The morphology are the lymphocytic, leukocytic infiltration, all the mucosa, diffuse sclerotic and sometimes atrophic change, and disturbances in regeneration processes. Like to the chronic enteritis, the chronic colitis also has the two types, the non-atrophic and atrophic colitis. Non-atrophic colitis also divided to the chronic superficial colitis and chronic diffuse colitis. Complications of the chronic colitis are the sclerosis of the large intestine, stenosis, spreading of the inflammation into the periintestinal soft tissue and peritoneum, avitaminosis, cachexia, and atrophic chronic colitis. That this is the precancerous disease of the large intestines. Here I would like to present you the clinical morphological classifications, types of the chronic colitis. First, the ulcerative colitis. Second, the Crohn's disease, granulomatous colitis. Third, the indeterminate colitis, that between the ulcerative colitis and colorectal ulcerative colitis. Then ischemic colitis, that develops to the arteriosclerosis, diabetes, vascular surgery, systemic vascular diseases such as scleroderma and rheumatoid arthritis, Wegener's granulomatosis, idiopathic lymphocytic phlebitis, amyloidosis as a complication of birth control pill use. Fifth type is obstructive colitis, that occur mainly during the adenocarcinomas, and other types of colitis, non-specific bacterial colitis, allergic colitis, and proctitis. The microscopic colitis, that include the two types of the colitis, the collagenous colitis, then lymphocytic colitis, the focal active colitis, pseudomembranous colitis, that mainly caused by the Clostridium difficile, and the amoebic colitis, and etc. Here I would like to present you the microscopic colitis, the mainly we meet during the practice in the labs. Here you see the hematoxylin eosin stainings and the subepithelial region. We found the presence of the band, the pink collagenous band. After using the trichrome and the Van Gison stains, we exactly find the presence of the collagenous bands under the epithelium, subendothelial collagenosis, we call it collagenous colitis. But the lymphocytic colitis differ from the collagenous colitis because here no increasing the thickness of subepithelial collagen. And let me say to you one secret about the colitis. As you know, because there is the high metabolic activity in the intestines, especially in the large intestines. Here normally present the lymphocytes, plasma cells. This is the normal conditions for the intestines. We only focus to the architecture of the crypts and the presenting of the intraepithelial lymphocytes, because when the lymphocytes present in the lamina propria, this is normal conditions for the large intestines. But if we found the intraepithelial lymphocytes, is the marker of the inflammation, and here you see the abundant number of the intraepithelial lymphocytes with the normal crypt architecture. Now let's discuss about the ulcerative colitis, or another name in your textbook writing the non-specific ulcerative colitis, or idiopathic ulcerative colitis, hemorrhagic colitis, or the ulcerative proctocolitis. The chronic inflammatory disease of the colon and the rectum with involvement of the intestinal mucosa and submucosa and ulcer formation. Ulcerative colitis is more common in persons of Caucasian race, in women and young persons. In active phase, the suppurative, hemorrhagic, and ulcerative colitis develops, but in remission, the sclerosis develops in this region. As a result, the large intestine undergoing of diffuse cirrhosis. It is the autoimmune diseases is considered that ulcerative colitis. Grossly, there's some specific features for the ulcerative colitis. In the colon, the typical pattern of pseudopolyps from the severe inflammation and mucosal erosions are found. In the acute form, in the activation form, the mucosal surface is wet and glaring from blood, and mucous with numerous petechial hemorrhages. Ulcers of various sizes can appear. They may be small, rounded, and superficial, or more irregular and somewhat geographic in configuration. In this ulcerative colitis, the nerve plexus also is damaged, and the innervation of the intestines is disordered. The trophical lesion starts. We call it ulcerative pancolitis. As we said, the wall of the large intestine is thickened as a result of the sclerosis. The gross pathology of the ulcerative colitis. The most intense inflammation begins at the lower right in the sigmoid colon and extends upward to the ascending colon. And here we see the ileocecal valve with a portion of the terminal ileum that is not involved. But the ulcerative colitis tend to be continuous along the mucosal surface and tend to begin in the rectum. We discussed about the pseudopolyps, and here you see the pseudopolyps can be seen clearly as the raised red islands of the inflamed mucosa, and between them is only remaining the muscularis. Here you see. And histopathologically, the inflammation of the ulcerative colitis is confined primarily to the mucosa. For example, later we'll discuss about the Crohn diseases, that Crohn diseases affected all of the layers of the large intestines. But in the ulcerative colitis, as we said, that inflammation is confined, is limited only in the mucosa. And the mucosa here, you see the eroded by the inflammatory process with the ulceration. Here you also see that undermines the surrounding mucosa, and the results of the ulceration often has a flask shape. You see here. And under the high power, we see the crypt abscesses. This is the histological finding, more typical with the ulcerative colitis. Abscesses we call the accumulation of the neutrophils, the inside of the lumen of the crypts. You see here, here. And finally, let us discuss about the Crohn diseases. Etiology is unknown of the Crohn diseases. Possible role of the pre-inflammatory cytokines in the pathogenesis may cause the Crohn diseases. Possible association with Mycobacterium paratuberculosis, measles and mumps infections. And associated environmental factors are the infection, smoking, consumption of refined sugar, high fiber. I would like say that the Crohn diseases mainly now they consider it the two factors, etiological factors. First, the immune pathway, and second one, the infections, as well as I said that Mycobacterium paratuberculosis, measles, and mumps infections also they consider it the viral infections. The most common in distal ileum and the colon. The IBD or the inflammatory bowel disease affect all race and both sexes. The incidence is generally higher in developed countries, especially in Northern Europe. Lack of dietary fiber, environmental and the genetic factors are infusing the disease progression. Grossly, the typical transmural lesion can produce anything from a small ulcer over a lymphoid follicle, we call it ephthoid ulcer, to a deep fissuring ulcer, to transmural scarring and chronic inflammation. Macroscopically, there are cardinal histologic features of the Crohn's disease. The first of them is transmural inflammation. The involvement the full thickness of the wall from the mucosa to the serosa. If you remember, just we discussed about the US, the ulcerative colitis, that we said that inflammation only limited in the mucosa. But in the Crohn's disease, the inflammation involves all of the layers. Then 1/3 of the cases have a granulomas. This is the granulomatous diseases. Extracolonic sites such as the lymph nodes, liver, and joints may also have granulomas. So deep ulcers may penetrate through the bowel wall to initiate the abscess or fistula. Inflammation is typically segmental, with uninvolved bowel separating areas of involved bowel. This is also the typically histologic features of the Crohn's disease. Grossly, the lumen or the relief of the intestine like the cobblestone. You see here the cobblestone-like mucosal relief. In the histology, we see the transmural inflammation, the affecting of all of the layers of the intestine. Here we see the mucosa, submucosa, muscularis, and here the serosa. The epithelioid granulomas with the giant cells present in the all layers of the bowel, and here shown the submucosal fibrotic area, fibrosis is the prominent here. And then the high power, here you see the Crohn granulomas, the granulomas during the Crohn disease in the wall of the large intestines, and under the high power we see with you the giant cells, the multinucleated giant cells. Here also you see very prominent cells. The complication of the Crohn diseases, the serosal involvement, the adhesions to other loops of bowel, bladder, abdominal wall, deep fissure ulcers, the fistula and sinuses, the formation of the strictures, fibrous adhesions, perforation of the bowel, perianal fistula fissures and abscesses, increased incidence of bowel cancer, sometimes significant bleeding from ulcers, and systemic complications similar to the ulcerative colitis, that they involve the skin, eye, joints, and liver. So we finished our lectures. Thank you very much.